Okay. So my name is Frédérique Naviaux, as I was saying, and I say hello from Ireland. So we're going to talk about pediatric obesity and more specifically the concept of co-obesity. This is an article that I wrote with my two partners in crime, Professor Pascal Jeanne and Professor Maximilien Gourdin, who are both working in the Université Catholique de Louvain. Myself, I work as the head of Summerhill Services in County Wexford, Ireland. This subject was recently published in September 2020. So our talk is going to talk about an introduction about obesity in general, but also obesity and addiction, a neural basis system and reward system, the intrafamilial dynamics, but also the correspondence between codependency and co-obesity, a few clinical considerations, co-obesity and COVID-19, and a new treatment for pediatric obesity. Obesity is a medical condition characterized by the excessive accumulation and storage of body fat to the point that it has a negative impact on health. In 2013, obesity was classified as a disease by the American Medical Association, but it has also been described as an epidemic. To measure obesity in adults, the body mass index, BMI, is used as it correlates with the amount of body fat a person has. People used to be considered overweight with a BMI between 25 and 30 kg per square meter, and obese once it was over 30 kg per square meter. But as children are not fully grown, we recommend not to use the BMI, but growth charts and the centile system. Various causes of obesity have been identified, the main ones being a combination of eating too much, not moving enough, having a genetic susceptibility or a medical illness, being on some specific medication, or suffering from a psychiatric disease. But 10 other putative contributors to the secular increase of obesity were reported. And these are an insufficient sleep, some endocrine disruptors, variability in ambient temperature, decreased rates of smoking, increased use of specific medication, like, for example, an antidepressant, as their indications are getting wider every day. Proportional increase in ethnic and age groups that tend to have a higher weight. The fact that most women these days are getting pregnant later in life, which might also be a factor in children obesity. Epigenetic risk factors passed on generationally, natural selection for higher BMI, and assortative mating resulting in an increased concentration of risk factor for obesity. Multiple studies have also demonstrated a clear relationship between food insecurity and obesity. Food insecurity is when a person does not know when she's going to have her next meal and where it will come from. The more insecure you are about food, the more you are at risk of obesity. According to the US Department of Agriculture, there's two types of food insecurities, either low food insecurity or very low food insecurity. The problem is that the cheaper foods, which are the only one that some people like low-income families on welfare, for example, can access, are also the unhealthy ones. These foods are loaded in fat, carbs, and sugars, and do not contain the right nutrients needed by growing children. Children fed on these do not get the right balance that will motivate them to go outdoors and physically exercise. This causes obesity. Children just want to stay indoors, watch TV, go on their computers and play video games because they do not have the energy to go and play outside to be healthy. There's also a lot of similarities that have been observed between overeating, let's say obesity, and addiction and substance use. The concept of addiction is complex. Traditionally, it was applied to excessive ingestion of substances leading to physical dependence, characterized by tolerance and withdrawal. It was solely used regarding the abuse of drugs that activated the brain's mesolimbic reward pathways. But these days, the term has a much broader meaning, as it also applied to designate some addictive behaviors rather than the sole use of psychoactive substances. Multiple work have shown there was a relationship between substance use and obesity. Both disorders disrupt the systems in the brain that balance immediate reward and need with survival requirements. When people use drugs, they temporarily feel good or experience pleasure. And you can see exactly the same when people eat food. They go through intense, though short-lasting feelings of pleasure. Exactly like drugs, food induces tolerance over time, which means that in order to reach and maintain a certain effect, toxicity for drugs or society in terms of food, you need to increase your intake. These compulsive behavior, using drugs or overeating, cycle between withdrawal and relapse, which suggests a similar brain functioning. Obesity and substance abuse are connected at multiple levels. First, regarding biology and genetics, regarding how much or where the body fat can be stored and how the body burns calories and converts food into energy, about the brain functioning, about environmental and developmental risk factors, including peer pressure, trauma, stress, or even parenting, health repercussions, intense urges and cravings, social circumstances, poor quality of life, but also, unfortunately, social stigma and discrimination, as both problems are often dismissed as poor self-control disorder and often considered as self-inflicted life choices. Let's see the neural basis and the reward system. Multiple studies suggest that the global obesity epidemic isn't triggered by a lack of motivation to lose weight, but that some food or some substances added to them can trigger an addiction process by activating in the brain the same reward system generated by drugs, the mesolimbic system, via dopamine. The surge of dopamine also impacts other cerebral areas relating to self-control, which explains how the ability to control strong urges for drugs or for food is compromised when suffering from compulsive, excessive, and chronic overconsumption. Our brains are designed and hardwired to respond to rewards. Without reward, survival is compromised. Indeed, both our behavior and action are motivated by reward. Unfortunately, many of the abundant and easily accessible foods won't create the above-mentioned feeling of satiety, fullness, or even satisfaction. Highly rewarding food will only produce short-lasting and intense feelings of gratification, leading the most vulnerable, biologically or environmentally, to misuse food in a similar way addicts misuse drugs. Food intake being controlled by a set of cognitive and emotional factors, morbidly obese people present with a reduction in dopamine D2 receptors and can develop a resistance to leptin, conducting to compulsive eating. Overeating has been shown to increase the release of endogenous opiates, augmenting the desire for food by determining the weight gain and obesity. Obesity is, as everybody knows, unfortunately, one of the most common nutritional disorders in childhood, with a lot of heavy consequences at short, medium, and long term, including the increased risk for adult obesity and numerous associated diseases. According to the WHO, the worldwide prevalence of combined overweight and obesity in children rose by more than 47% over the past 30 years. The causes of childhood overweight and obesity are multiple and interrelated. I've already mentioned some causes that were biological, genetic, social, and environmental, but in this section, we are going to focus on how factors from within the family participate to the spread of obesity. So it has been noticed that parental influences matter a lot. So do dietary intake patterns within the family and the fact that parents are themselves already obese. The level of parental education and their level of literacy also matters. The less educated the parents are, the lower their economic status is, and the higher the risk of the child to become obese. There's also, as other contributing factors from inside the family, the parenting style. The more permissive, the higher the risk of obesity. Child feeding practices, but also poor sleep behaviors. That would include a late bedtime, multiple night awakenings, the fact that different people in the family share the same bed, and a lack of sleep routine. The interesting thing is that if parenting was proven to influence child eating and weight, well, child eating and weight were also found to influence parenting, making it a bi-directional model. The psychological underpinning of addiction to alcohol, hard drug, or overeating often involve more than one person. It involves a whole system. The dynamic is different according to the age of the patient. A child, of course, has no choice but to cooperate in whatever type of relationship the ruling adult sets up. When a person grows older, it becomes more complicated because their own psychological quirks help define and shape the codependency relationship. In 2017, Harvard explained how families influence children's dietary choices and risk obesity in many ways. The term codependency originates from the realm of addiction psychology. It is essentially used to explain how addicted people are enabled to maintain their addiction due to other people. In this context, an obese child can be enabled by a parent who facilitates, either voluntarily or not, their or that addiction, which we call co-obesity. So the interesting thing is that another way, a new explanation for pediatric obesity emerged from the observation that parents give treats to their children and extra food at meals in order to gain love and affection from them. The term co-obesity came from the fact that both the parents and the child become psychologically dependent on the treats and the extra food provided to the child, reinforcing and enabling each other voluntarily or not. This codependency is often initially based on positive reinforcement. This is quite well understood and used by the food industry to advertise their product. Give them food, get the love. To illustrate this, just a simple example. Let's talk about Sam, who is 5 years of age and who, like most 5 years old, really loves trips to the supermarket with his mommy. He often picks up some sweets, some chocolate bars, things that he saw advertised on TV, and he asks his mom to buy them for him. He even tells her that if she gets them for him, he will give her a big kiss and he will be a good boy. So mom often buys the requested treats. It costs little money, avoid a fight with the child, keep him quiet, and makes mom happy to have such a loving and well-behaved little boy. This is a positive reinforcement. It can, of course, transition to negative reinforcement, avoiding emotional pain, when the extra food and treats are given by the parent to avoid hostility or rejection from the child. The situation becomes difficult when mom refuses to buy the treat requested by Sam. She would like to resist sometimes, knowing that these foods, high in fat, in sugar and sodium, are not good for him. But she knows that if she does not get him the desired treat, she will have to deal with an angry, crying and shouting Sam. She can't stand her son to be unhappy and even less angry at her. Therefore, she does not dare not to buy the treat that Sam wants, which is a negative reinforcement. In that case, both parents and child become hostage to the treats, the food. Actual addictive tolerance may develop, as the child might request more and more treats, food, and highly pleasurable food, or the parents himself independently might want to give more treat to the child, fearing that the child does not get enough, for example. At a stage, the parent might notice that the child has become overweight and might attempt to cut back on the treats and the extra food. But parental withdrawal symptoms resulting from the loss of love, affection from the child if treats are reduced, may prevent them to do so. Likewise, the child does not want to go through withdrawal and may reject the parent or display angry behavior because of the loss of food fixes. Aversion to anger or cold shoulder from the child motivates and perpetuates then the parental enabling, as the fear of rejection may surpass the desire for love. Grandparents and close relatives, like aunt, uncle, godfather, can also be part of this codependence, enabling overeating and obesity. We have now reached the section regarding obesity and COVID-19. The COVID pandemic has led to laws and policies, including school closures, lockdown or shelter-in-place laws, and social distancing or even social isolation requirements that translate into potentially risky and damageable behaviors for our young ones for the duration of these laws and policies. These include, amongst others, a loss of routine, a lack of structure, a change in eating habits, like more snacking, binge eating, or going for unhealthy diet, a decreased level of activity, some sleep disturbances, some mental health disorder, spending less time outside, and spending an increased amount of time on the screen. This combination of factors certainly favors obesity. Indeed, when you have a lot of stress, and when you're bored, and when you're not moving, and apart from all that, you have access to something that makes you feel better, you do it. The food becomes like your drug. A summary of the increased risk of co-obesity during confinement could be stress, sleep disorders, activation of reward centers, sedentary behavior, fast food and ultra-processed food use, loss in exposure, reducing the vitamin D, more screen time, and a rise on sugar-sweetened beverage consumption. This is all summarized in the schema from Noguera de Almeida. And our last section, which is about a new treatment for pediatric obesity, it means that we need to use new ways of thinking. Family-based intervention for pediatric obesity should take account of the addiction model, as traditional approaches, including lifestyle modification of diet and exercise, have failed to give significant long-term results. We recommend a model of intervention in which classic addiction medicine technique of withdrawal and abstinence are combined with behavioral addiction treatment methods. This intervention starts with a procedure of staged food withdrawal for both children and parents. So behavioral addiction treatment methods involve alternative behavior like going for a walk, reducing the stress level, distraction techniques, distress tolerance, and trigger avoidance.